Hi, I'm Smriti Khanna,
Hi, I'm Dr. Mahesh Menon. I'm a pain medicine and palliative care specialist.
and welcome to the next episode of our podcast, Living Well. Today on our podcast, we have Radhika Banka, who is a chest physician, a pulmonologist who I've had the pleasure of working with for a while now. Welcome, Radhika.
Thanks, Smriti. Thanks, Smriti and Mahesh. It's my pleasure to be here. So I'm really excited for this podcast.
So, Radhika, can you tell us a little bit about your journey in chest medicine till now?
Yeah. I trained in respiratory medicine at PD Hinduja Hospital, and then I was fortunate enough to go to United Kingdom, UK, for a few years. So I was in UK for 4 years. And actually, I encountered a lot of palliative medicine during my stint in UK, and especially I was at Oxford for 2 years, and they've got a great palliative program there, including hospice care within the hospital campus. So that's where I was very attuned to palliative care. And then I came back and joined Hinduja Hospital as a consultant. So I've been a consultant in respiratory medicine since the past 4 years there now.
So I just wanted to understand you spent time in UK, you were in Oxford. What makes someone who's so specialized in medicine, what makes them come back to India?
I think it's a lot of factors. So I think it's a lot of professional, personal factors. I don't think it's just one thing that makes you come back.
Correct.
But I guess in general, the joy of practicing medicine is much more here. And that's, I guess, just because of the diversity that we see here, the sheer numbers. And not to belittle, but NHS is a very government setup. It's a very by the book, a very formulated setup in that sense. So, but medicine in India is more, of course, more chaotic, but definitely more joyful as well.
So that's going to be very encouraging for any medical student who's going to watch this.
Yeah,
Because
yeah.
we think about brain drain and people leaving the country, and when we see people who are young, dynamic, and experts in their
back.
subject coming back,
Or,
me included. But yeah, coming back to India,
yeah,
that way.
absolutely. I
The
mean, I
young
would.
dynamic to squeeze your name in.
Yeah, yeah, definitely. But Radhika, what something that I wanted to know was that in your practice, what are the lung diseases that you see which have a bad impact on quality of life, or which may be going on lifelong?
Yeah, so I mean, as the name suggests, so most of your respiratory problems, the main symptom is cough and breathlessness, and any chronic disease which has this is going to negatively impact your disease. So the most common chronic conditions that we see is something known as COPD, or chronic obstructive pulmonary disease. Interstitial lung disease or lung fibrosis is the other one, which is a chronic disease. And these two diseases can't be cured, so you can keep them under control with medication, and unfortunately both of them can progress over a period of time. So I think in terms of what majority of diseases that affects respiratory illnesses, I think would be these two, which can negatively impact quality of life.
Wasn't there a lot of discussion, I remember, around lung fibrosis after COVID,
Mm.
around COVID?
Yeah, absolutely. So during COVID, I mean, it was mainly it affected the respiratory diseases, but like the number of people who had severe COVID was to the tune of say 15 to 20%. But thankfully, like with most of the other post-viral infections, like the fibrosis was resolved in around more than 95%
Oh,
patients.
wow. Okay.
So I mean, now if you see a patient with fibrosis, you would never label them post-COVID.
Post COVID.
So majority of them have resolved. So now the reasons for fibrosis would be completely different.
So if someone's listening to this and they don't understand what fibrosis means and what can it do, so can you just simplify it and explain to us why is fibrosis so bad?
Okay, this is very simple language. So our lungs are basically they're like sponge.
Okay.
So when you take a deep breath in, your lungs, which are like sponge, they expand, and when you breathe out, your lungs contract, so they shrink. So when you breathe in, they expand, so they're taking all the air in. When you breathe out and they shrink, the air goes out. Now just imagine this sponge getting a little harder. Okay. So if the sponge is getting a little harder, so the amount of the lung that is expanding and contracting is reducing. So just in simple language, so if the amount of air that is going in is reducing and coming out is reducing, so the amount of oxygen going in is reducing, and as we all know, oxygen is needed for
Needed.
every function of our body. So lesser oxygen means more breathlessness, and cough.
Got
So
it.
that's basically what fibrosis means. And unfortunately, a lot of times this fibrosis is not reversible. Meaning, so if there's a little bit of fibrosis that has set into your lungs, we may be able to progress the halt of it. Sorry, we will to halt the progress of it, but we may not be able to reverse it back.
Fair, okay. And do you have any statistics for our country, for India, in your practice, that what is the percentage roughly of people who have conditions like these, where the lungs are damaged?
So I don't think we have a number in the general population, but there are ILD registries, so registries of patients with problems of lung fibrosis, and the percentage of people who actually have lung fibrosis would be to the tune of say 22 to 30% in these registries. So it's not a small number to be honest.
So you say ILD registry. What does that mean?
So that basically means all the patients who have interstitial lung diseases are monitored from across the country. And there is proper published data in journals to show what the ILD burden in our country is.
And how bad is that?
Uh, so I can't remember the numbers on the top of my head, but it was much more than what it's in the West.
Okay.
We have more fibrosis in India than in the West. You spoke of cough and breathlessness. Are these the predominant problems that patients with chronic lung diseases face? When they come to you in the OPD, what do they talk about? Like, what are the problems they are facing?
So predominantly it would be shortness of breath. It would be cough. In patients with COPD, they can have a lot of phlegm or mucus, or commonly known as bulgum production. That could be the thing. A lot of patients would classify breathlessness as fatigue or lethargy. So that could be non-specific. Weight loss is the other thing that they may come in with. And of course, when you inquire, then you might get more of the other non-physical symptoms that they're suffering from as well, because of the chronic respiratory disease.
What are these other non-physical symptoms that you mentioned?
So I think just a lot of these patients are breathless.
Correct.
And being breathless is no fun. It's very anxiety. I mean, it causes a lot of anxiety. It's frightening to be breathless. So a lot of these patients are not mobile. So they're quite homebound. Getting out of the house is a task. A, because of fear that they might not be able to breathe, and if something goes wrong. B, and they lose their confidence. So just being homebound starts affecting them mentally in a way that they're depressed, they're quite anxious. They at times they have to leave their jobs because they can't cope with the travel. So I think these are the non-physical symptoms that we don't very commonly address, or we don't very commonly talk about.
So it's very interesting how she assessed the total person history. She spoke
Yeah.
about the symptom,
Yeah.
then the impact on the person, and
And the burden.
Burden.
Now, you were telling us a few things, different things that, like a person with breathlessness, they can talk about it in few different ways. One you said was fatigue. One is tiredness.
Yeah.
Anything else they say? Like instead of saying breathless.
So the other thing is, when people are breathless, they automatically reduce their activity. So say, like 6 months back, they were at least getting out of the house, climbing one flight of stairs down, and then being able to go to the market. And now they're not able to do that. But they don't really talk about that, because they're just homebound, they're just able to do a few things in the house. They don't feel breathless. I think that's somewhere that you really need to get that history out of them. So it's only when you make them realize that, okay, look, 6 months back you were going to the market, but now you aren't, because you've just got conditioned to your body, to yourself and your mind, to the fact that, okay, I'm breathless, I cannot get out, so let me just stick around to the house. So that's the other thing that you really need to get from the history, in terms of how it's been progressive. Because with breathlessness, you just adapt to you can't
Your
stay
situation.
You can't stay breathless forever, right? You can't be breathless, so you'll just like start limiting your activities gradually, and you might not realize it until somebody actually points it out to you.
What's the age bracket of people, and is there a gender distribution? Is it like
So for lung fibrosis,
for the patients who are coming to your clinic with lung diseases, like interstitial lung diseases, or say fibrosis, what is or COPD for that matter?
correct.
They're
The
all different.
demographics.
Yeah, demographics. Yeah.
So lung fibrosis is probably like the late stage of interstitial lung disease. So generally it is seen in like the elderly. So when you say elderly, like above the age of 60 or so. Very rarely, of course, you can see it in the young as well. But predominantly you would see it in the elderly. COPD, again, it's most commonly caused by smoking.
Smoking.
Yeah.
And in our country, actually, more than smoking, it's the indoor air pollution that we are exposed to, indoor and outdoor air pollution. So just biomass fuel exposure or chulha exposure is probably the biggest risk for getting COPD in our country, as compared to smoking, which is the biggest risk factor in the West. So again, these
That's
patients
interesting.
tend to be slightly older, above the age of 50 or 60.
Okay.
But I just wanted to come back to the breathlessness bit. You also mentioned that it has these kind of things in the sense that activity gets reduced. But now, if a patient comes to you and says that I want to exercise, what would you say? Would you encourage patients to continue exercising even when they are breathless? Because that is a very scary thing, right?
Absolutely. So I think first you need to optimize their respiratory condition as much as you can with medication. So whether you need to give them inhalers or whether you need to give them steroids, antifibrotics, whatever. So you need to optimize the medical condition to the best of what you can. And after that, yes, you should advise for exercise. But I think you need to, with the caveat that you should do as much as you can. Okay. You can't expect them, a breathless patient to be walking like 3 kilometers at like 6 kilometers an hour of speed. That's
You
not
mean
going to
just
happen.
do only as much as you can.
As much as you can. But of course, if you can, then challenge yourself. So say today, if you can walk for like 5 minutes comfortably, then say after a week, try to make that 7 minutes. And then after that, try to make it 9 minutes. So try to have incremental increase in your exercise capacity as much as you can. Again, the extent of breathlessness is also what is going to determine how much they can do. So, if somebody is not very breathless, you would encourage them to do even something beyond exercise, like, a little bit of weight training, a little bit of resistance training. But if somebody is on oxygen, then you would limit them, limit their activities. And this is where pulmonary rehabilitation really helps.
Okay.
Because they can tell you sequentially how to go
Exactly.
up and up and up in terms
Absolutely,
of
absolutely.
so for somebody with this kind of chronic breathlessness, maybe like having a gym trainer would not be as useful as actually having a somebody who will help them through pulmonary rehab, like a therapist who will help them through the pulmonary
Absolutely.
rehab bit.
So pulmonary rehabilitation is basically in simple language, it's a exercise and a physiotherapy program for patients with any chronic respiratory illness or breathlessness. And it's basically, what does it entail? It basically entails a few breathing exercises. It entails a little bit of muscle movement exercises. If the patient can, a little bit of resistance or weight training, not very high weights, but small weight training. And that has significantly shown to improve symptoms. So it has definitely shown to improve breathlessness in patients with these chronic respiratory illnesses.
So I just want to ask you, when we say chest physiotherapy in a country which is not too, things are changing, people are adapting to exercises and better health options. What is the relevance and what's the importance of chest physiotherapy when you advise it in your clinic? How relevant is it, and what is the approach of patients towards it?
So it is extremely important. It's of paramount importance, because as much as you have your medical management for these chronic illnesses, you need your non-pharmacological management as well. And that goes for any other chronic illness.
Correct.
The same is for any respiratory illness as well. So it is definitely very important. Now, in our country, it depends. So, of course, there are resource limitations as well. But then there are there are a lot of pharmaceutical companies who started these pulmonary rehabilitation programs.
Okay.
More for like, on a basis of philanthropy. So these are very patient-driven programs. So the patient actually gets these programs for free online. So, and of course, if you can afford, then you can get a personal pulmonary rehab pulmonary therapist to see you as well. So definitely there are a lot of avenues now for patients who want to, and these are done online. So even like, just for weight training, they will not even expect you to get dumbbells. They'll just ask you to get like 1 kg, a 1 liter water bottle, and just do a little bit of weight training with the 1 liter water bottle.
Absolutely. So it's a very important message for people who are listening to this, that chest physiotherapy exercises based on pulmonary rehabilitation are very important in the overall care, because helping with clearing your secretions, strengthening your chest muscles, all of that is a very important part of the treatment process.
Yeah, absolutely. So the other thing we always also neglect is that breathlessness is, of course, caused by your lung pathology. So you might have fibrosis or you might have COPD, but just muscles. So our muscles, which are, if they're weak, muscles like anywhere in the body. So even to move your hand, you need muscles. So if they are weak, they tend to use more oxygen.
Right.
Oh, yeah.
So if they're using more oxygen, then the amount of oxygen that you need to like do any activity to move from here to here, you're going to be more breathless.
Right.
So it's so important to preserve your
Muscle mass.
muscle mass. And how you're going to preserve your muscle mass is going to be through, of course, good nutrition, and it's only going to be through mobility, right? So if you're just sitting, or if you're only going to be in bed, you're eventually going to move, lose your muscle mass. And we know that these conditions are very catabolic. Catabolic meaning that your energy consumption and the way you lose muscle is very quick, is much more rapid than what a person without any respiratory disease would. So just doing pulmonary rehab, being active, doing exercises as much as you can, of course, will prevent your muscle deterioration as well. So with that, of course, you're conserving energy, you may be able to improve your breathlessness.
Yeah, that's what I was going to ask you. Like, there are real life benefits in terms of how you feel, how long you live, how well you live, based on actually, it may not, these things are not related to medication. Like pulmonary rehab itself can play such an important role.
Yeah, and there is documented evidence. There is good randomized control data evidence to show that pulmonary rehabilitation improves symptoms. It does not improve mortality actually, but it definitely improves symptoms.
The quality of life.
Quality of life definitely improves. It prevents exacerbations.
So even though the length of your life is not increased,
but your
at least
quality
your
is
quality of life is definitely increased.
So I'll just add one point here, is that when people come to us, especially the elderly who are in a lot of pain, we find that they are not able to walk too much because they have knee arthritis or so on. And when the pain goes down, we ask them, how much are you able to walk? And then they say that we can't now because we are breathless. So earlier, the pain was causing them to not walk too much. So they didn't know they were breathless. So that's why whenever we treat, and this is something that I keep telling all the pain specialists when we train, that if you focus on just reducing the pain, you also need to focus on the engines, the reserve, to help them breathe well. Otherwise, you're going to have a situation where they are going to try and overdo and get more tired. It's going to be counterproductive. So it's a whole person.
Yeah, absolutely. I mean, in general, there's data to show that if you are breathless, forget any even if it's not a respiratory condition, just being breathless as compared to somebody not being breathless increases your mortality. So even if you don't have a respiratory problem, it's important to be on your feet. And definitely if you have a respiratory problem.
So whatever you're saying is like absolutely intuitive and common sense medicine that doctors often talk about. Eat well, do exercises.
Keep mobile.
Stay yourself mobile. Stay active, stay mobile.
Active, I also wanted to discuss the anxiety component which you were talking about. I remember taking care of one patient with late stage lung fibrosis, in which every time she would get breathless, she would get anxious. Her son, who would be watching her, would also get anxious looking at that, and that would be like a whole spiral within the family. It would be so difficult for them to it was so difficult for them to look at her going through this. But what advice do you give patients or even families about the anxiety component, about the worry aspect?
So you can break it down into two parts. What would you advise the patient who's experiencing breathless and who's anxious? And the second part is, what would you advise the caregivers
the caregiver
of the patient who's...
So, breathlessness is very complex. So, of course, there's a physical aspect to it, which we treat. And then there's this whole big psychological aspect, which we completely neglect,
Hmm.
unfortunately. And the physical aspect is something which is at least a little objective, can be measured. You can do your lung functions, you may be able to do CT scans to see if your fibrosis or
Goes
COPD is
up or
getting
down.
up or down.
Hmm.
But the psychological aspect is you can't measure that. It's not tangible. Uh, it's a big factor.
Suffering.
Exactly. So you're suffering, and it's a big factor to be encountered in patients who have breathlessness. And there is a role of a lot of non-pharmacological treatment options as well for breathlessness. And I was reading this very nice article in the European Respiratory Journal where it said for chronic breathlessness, treat the lungs, fool the brain, and appease the mind.
Huh.
Can you say that
So,
again?
treat the lungs, fool the brain, and appease the mind. So basically, of course, you want to treat the lung. And that, as I said, there's a big mind component to breathlessness. So you do need to address the psychological aspect of it. And there is now evidence to show that, just behavioral therapy,
Yeah.
cognitive
Yeah.
behavioral
Yeah,
therapy,
yeah.
mindfulness, they all help with the breathlessness. And how they help, they postulate the fact that just the anxiety or depression associated with the breathlessness gets relieved because of this, which leads to better symptom control. So definitely for patients and caregivers, I would strongly recommend mindfulness, cognitive behavioral therapy for this kind of a situation that you alluded to. And then of course we do have certain medications like morphine, which you guys are more
Hmm.
aware of and more experienced to use that. And just simple things like using a handheld fan, using
Yeah.
supplemental
Yeah.
oxygen. So these were the things that I would definitely advise my patients.
Yeah.
And what if the caregivers are anxious about their loved ones who are facing breathlessness? What would you tell them about the breathlessness, the caregivers?
So I think we need to reassure them. Reassure them. So I think first is, of course, you have to make sure that you've optimized medical
The
care and
medical
you've
care.
literally offer them everything that you could, like including a lung transplant if they fit for that.
Hmm.
So you have to make sure that that's done. And then beyond that, then you really need to look at non-pharmacological measures like what we spoke about. And I think we need to we need to reassure the caregiver that uh, it's a perception. Breathlessness is a perception. So there are going to be times where the perception is going to be very high.
Yeah.
There are times when the perception is going to be low. So
And sometimes that may not have a reason.
that may not have a
People
reason.
want a reason for
Everything
why
you
is
may
she
not get
getting
exactly.
breathless
You
at
may
this
not get a
point.
reason for
Yeah.
that.
Yeah.
So I think you need to deal with it. If it's causing too much anxiety to the patient, and of course we can give some medications to
Medications
calm
for
it down. But I think we need to let them know that we need to reassure them that it's more of a perception, rather than it probably might not even be like the disease worsening or
Hmm.
or an acute worsening of the disease.
You were telling me the story of one of your patients who has a lot of breathlessness, but the family has managed her very effectively at home.
Yeah, I in fact, unfortunately, he passed away last year. But this gentleman was a severe case of COPD, and in fact, I had seen him earlier in 2013 when I was a resident, and he used to come to the clinic at
Oh.
Hinduja, and he'd had type 2 respiratory failure, meaning he was on home BiPAP since 7 to 8 years, and he did have 2 hospital admissions in 2021 and 22, including both of them in the ICU, including one of them where he needed to get intubated. Or
Mm.
that was the first one. And after the second admission, he was very clear that he did not want to come to hospital. And his wife was absolutely okay with that because she'd seen him gradually deteriorate over the past 10 years. So towards the last 5 or 6 months of his life, he was on 6 to 7 liters of oxygen. So they literally connected two
Two
concentrators. He
together.
was on a BiPAP, which nearly for 18 to 20 hours a day. So they had two BiPAPs as well as a backup. And there were times when his saturations dropped to 50 or 60%, but the wife exactly knew what to do in those situations. She exactly knew to okay, increase the oxygen. If he wasn't comfortable, give a little bit of morphine. And then eventually, in a few days or weeks, he passed away. But I think they were very clear in terms of not going to hospital. But more importantly, they had a proper action plan at home, and they were very well prepared uh, they exactly knew what they were getting into, or the last few days or the last few months would entail. And I think that's very important, because again, breathlessness is scary for the patient, for the caregiver. So if you're seeing saturations of 50 or 60%, it's absolutely terrifying. But if you know that this is getting them to hospital is not going to be of any use, or it's going to be a terminal event, then you need to plan all of this in advance. You can't be planning it at the time when the saturations are 50. You can't do that. It has to be planned few months or even a year, and that's when you guys would be very useful. So, but that is something that the patient and the caregivers are very scared to even address.
So you said so many things in this just last 3 minutes, which is like a wealth of information. So the first thing that you mentioned about was, you said coming to the hospital was not going to be of use. So if there are people listening to it, generally people say, how can a doctor say coming to a hospital is not of use? So we have to explain to people what prognosis means, which means people know that there is a particular condition, treatment is not possible. So what are the statistics with lung diseases? And when do you say that, all right, what are the outcomes or mortality rates, or some numbers or some figures that you could help us understand this better?
So I think for COPD and lung fibrosis, the two main conditions that we're talking about, the statistics would be slightly different. But if you've had like one hospital admission in the ICU for a COPD exacerbation, where you've had type 2 respiratory failure, meaning your carbon dioxide levels have gone up and you needed BiPAP or you need intubation, your 5-year mortality is nearly 60 to 70%, meaning 60 to 70% are going to die within 5 years.
So these are the statistics as of now that are
as
available.
of now. For lung fibrosis, it's even more. So if you're admitted with an acute exacerbation, meaning your fibrosis has gotten worse, and you're admitted with an exacerbation, the chance of you surviving and needing ventilation, intubation, the chance of you surviving that episode is probably 20 to 30%. And let's not forget that even if you survive these episodes, what you are left with, or
the lung
capacity,
or
the
lung function,
new baseline that you come out with is much poorer than what you were.
So you're almost bedbound if that happens.
Yeah, so say if earlier you could walk, before this hospital admission, you could walk 100 meters. When you come out, you're probably going to be able to walk 5 or 10 meters, and that's going to be your new baseline. So with every hospital admission or with every infection that with these with these conditions, your performance status or your baseline definitely drops further. So it's like a trajectory which is this way, and if you have one event, it could just directly fall down.
Because you also mentioned, there was some discussion that you would mention something about lung transplantation. So the next question that people may ask is, then why can't we just transplant the lung?
So lung transplant is a process. So you need to, it's not as easy as we think. So you need to the patient is, I think the most important is that the patient needs to be convinced that they're ready to go through the process. B, you should fit the criteria. So in our country, lung transplant, you would generally not do it for anybody above 65. So transplant itself is, A, you need to fit the criteria. B, you need to do it, you need to be assessed for it, whether you fit. Third, you need to go on a waiting list for the transplant. And fourth, the financial implications as well. And let's not, lung transplant is expensive, and you need to do lung transplant when you are at least able to walk. Or at least you are on oxygen, but at least you're slightly mobile. Exactly. Because the outcome is going to be much better as compared to somebody who's bedbound. So in this whole process of starting to think about lung transplant till the time you actually get a lung transplant is going to be a few months minimum. At times it can even go up to years depending on which state you are listed in for your transplant. So you can't be like, today I've got somebody who's bedbound, let's get a lung transplant, tomorrow you get one. That's not how it works. So it requires a lot of mental, physical, psychological, emotional counseling, support, and that's when you would think of a lung transplant.
The third point that you raised was the most I think as palliative care professionals it resonated very well with us is the fact that she mentioned that the family was very well prepared to handle everything at home. So
I
how
think
much time
not-
does that take?
How
And,
much time does that take? And not panicking is such a important thing, right? As
Yeah.
you said, 50 sats, 50% saturations, anybody would panic looking at that.
Correct, but I think that's where exactly this whole preparation is needed, and this cannot be done when somebody is in that situation. This has
Correct.
to be done when they've electively come to see you in OPD,
When they're well.
when they are relatively
Hmm.
well. That okay, and you've developed a rapport with the patient and the family. You know what he really wants. If they've got very clear views that I don't want to go to hospital, so you need to explain to them that, look, if you don't want to go to hospital, what does it mean?
Yeah.
So just not going to hospital
getting
is not an option. But
complete information on
Yeah,
both
yeah.
this versus this,
Exactly.
understanding
Exactly.
and what is important for your happiness, your quality of life, minimizing
Absolutely.
suffering.
Absolutely.
But tell me, how many patients and how many families have that kind of conversation with their pulmonologists in our city or in our country?
Not a lot. I'll be very honest about that, because as much as I'm very pro starting these conversations, not of course on the first visit, once you've developed
Absolutely.
a rapport, but a lot of people are just scared to talk about them. Just the thought of that they're going to get more breathless over time, that they're going to be in a worse situation than what they are right now is just very scary for them. And this unfortunately happens a lot of times, when these patients have not discussed this, and in a frenzy they land up in the hospital on saturations of 70%, and unfortunately turns out a terminal event. But I think just having these conversations, and also the other thing we should not forget is having the kind of resources to set up all of this at home. To manage all
That's
of
true.
this, you need
manpower, money,
space, and also the equipment, right? You need
She had two BiPAP machines, one in case this
in case one
concentrators,
two concentrators,
and of course the nebulizers and all of that so you need to have that kind of an infrastructure. You need to have a nurse. Even manpower, just a ward boy, somebody is not going to be useful for this. So that kind of, there's a lot of caveats to this, so I don't think it's very easy to do it, especially I think for respiratory, because it's a very acute, things can go wrong within seconds and minutes. But it's not undoable. So if patients do have that, express that desire, and if the family can fulfill it, I think it's I'm sure it's very comforting for patients to be in their vicinity, in their surrounding during the last days.
And India is known, we are a country of low resource. In a low resource setting, we have done so many innovative things to take care of ourselves. So I don't think this is far away. We can probably, there'll be some workaround. We'll learn something.
I think that putting two concentrators together and
It's
making
very
them
novel.
work is also an innovation. Like I have never heard of it actually being done or described in literature. It's just something that we have kind of
innovated,
worked on, no?
Yeah, even like high flow, like the high flow nasal cannula that is set up at home. So where's the oxygen supply that's coming? That's from concentrators, right?
Yes.
So which is very innovative. Like in the hospital, that when you use it, you've got a central oxygen supply. But some patients who need it at home, or who very keen to go home but have very high oxygen requirements, so there is setup, and I think that's very indigenous.
You spoke about patients with chronic lung diseases. What happens to them when they get hospitalized? What about what happens to them if they need a ventilator? What is the kind of impact that has on the lung for a person who has a chronic lung disease, not a normal lung?
So I think it depends a lot on a lot of factors here. So I think it depends on what kind of a lung disease we're talking about. Whether it's COPD, whether it's interstitial lung disease, or whether it's something else. What's the extent of the disease? How severe is the disease? Is it like still early disease, or it's late disease? What's the age of the patient? What are the comorbidities associated with it? And how bad is this current episode? So I think based on all of these factors is when you would be able to decide, what the impact of a ventilator would be on the lungs.
Correct.
But in general, like with advanced lung disease, going on the ventilator is not a good idea, just because of the stress that it causes to the body. And B, the biggest concern is whether you'll be able to get off the ventilator, because will your lungs have the capacity or the strength to,
Breathe on their
to
own.
breathe again, to come back to normal functioning without the help of the ventilator. Um, and if you don't have that, then you may be subjected to something called a tracheostomy, which is a hole in the neck to help you
To help you
breathe,
breathe better.
So now whether you want that, whether you want to live with that, because that's got its own other challenges in itself. Uh, so going on the ventilator or not, um, if you've got a chronic respiratory disease, should 100% be discussed earlier. It can't be a spur of the minute when they've come in with saturations of 50% and you're having a conversation with the family, or do you want to put them on ventilator or not? That's not the time. But yeah, I think at least in that front, a lot of patients are very clear, and the family to a certain extent is quite clear that they don't want the patient to suffer. So they do have the insight of not putting them on through the ventilator, because they've seen them suffer over the years, and they they really know what it would be to put on the ventilator, and even if they do make it miraculously, what the quality of life would be.
If I mean, I think that what you are talking about planning for the future, even if it is about hospital or home or ventilator, how do you initiate a conversation like this? Like, when do you discuss this with a patient? What do you tell them?
What's that trigger that makes you say, now I need to have this conversation?
So I think when the patient starts focusing a lot on their quality of life, when it's not about just getting me better, it's about when they start talking about, oh, doctor, whatever time I have left, I want to live it well, I want to like play with my grandchildren, I want to do this, I want to like do this, but I don't want to suffer a lot. I think that's the time to start those conversations. um, Again, I think there's no right or wrong answer to this, but I think a lot of it depends on the kind of rapport that you've developed with the patient and the family over a period of time. Because I think somewhere it's also your responsibility to tell them what the future entails. You can't give them a very rosy picture of how things are going to be, nor do you want to like make it very ghastly for them.
Absolutely.
So you need to like give them a picture that this may happen, and give it a thought, like how would you want it to be. So I think I would just initiate the conversations. I would also talk about palliative care, especially when the symptom burden is much more than what only medical management can do.
Right.
And I think once you leave it open ended, you give them some time to think, a lot of them actually then do want to get to know more about it, converse more, very ready to meet the palliative physician.
So in my experience in India, most conversations for good quality of life start when they have hit very bad quality of life.
Yeah.
I just want you to kind of reflect and let us know, as a physician, in your experience over the years, how many people in India or families have come to you directly talking about quality of life, asking for a good quality of life oriented conversation?
So I think, again, probably because I practice in a private setup, people do have, so it might be a very biased population that I'm probably dealing with. So in this population, I think people do talk about, quality of life centered.
That's very
care.
heartening to hear that people, because in a lot of chronic conditions, be it respiratory, neurological, nephrology oriented, a lot of times is that partnership, once that trust builds up, and how we share enough knowledge with each other to understand ourselves better. But quality of life conversations, what's your take on this, Smriti? Is it something that we see commonly, that quality of life care conversations coming up?
I agree with you when you say that quality of life is one trigger. I think what I also hear is that when a patient talks about a symptom a lot, he or she may not equate it with what it's
With direct
actually
quality.
doing to squat, but keep saying that I'm feeling very
This is
breathless,
happening. This is happening.
or talks about how they were in comparison with, say, a few months or a year ago. That might be a trigger to talk about, let's talk about what can happen going forward. A third thing I think is any admission. really
Yeah.
puts you through that frame of
Correct.
mind.
Yeah.
Absolutely.
Because in any admission, if you are breathless and you have come to the hospital, you've probably at least thought once that, oh, I'm going to die. You
Yeah.
know, a patient must have thought, or a family member must have thought
Absolutely.
about it at least once that, oh, is he going to
Correct.
get out of here
Yeah.
alive or not? How am
Correct.
I going to be taking him home?
And I think with respiratory, it gets even more because you're very symptomatic.
Mm.
Like you're just
Mm.
breathless all the time. Like
Mm.
it's sad, but
It's
you know.
constant.
So people, I think, also think about quality of life, because if you're just breathless all day long, you know, so it's not
Literally,
a nice feeling. Yeah.
you
So
cannot focus on anything
you can't
else.
focus on anything. You can't do anything else. You know, you're limited. So I think probably people think a little more about, you know, like, is this how I want to live, or is
Yeah.
this how it's going to
Yeah.
just continue? So I think probably in respiratory, it also comes to that.
You know, this one thing about how, like you were talking about anxiety, and even when we have spoken about patients, I remember you talking about how either the family or the caregiver needs to be very calm. You know, like that in itself is a good indicator that there is such a psychological component to the
Absolutely.
breathlessness, that that itself, just that fear is a trigger for admission or worsening or any of
Yeah.
that. And the fact that you have a calm caregiver who is taking
Yeah.
care of you, or even as a patient, you know that, oh, this is a cycle, and this is what
Correct.
I have to do to get better. Like that in itself talks about the magnitude of the psychological
Still, yeah.
impact that the breathlessness will have on the brain, no?
You have the patient saying that, I'm sorry I interrupted, the patient saying that, doctor, I get unwell, but he or she, whoever's there, very strong, they're very strong.
Correct.
That's
yeah,
why I feel,
yeah,
and it's such a calming influence on them that
Yeah.
to have
yeah,
a
and
caregiver
then I
who's
have had
sorted.
patients. There is going to be one religious photo on the
The
in the
spiritual
Yeah, the
room,
strength.
spiritual strength.
and they will say, oh, whenever I get breathless, I just keep looking at
Yeah.
that photo, and I chant, or I meditate, or I pray, and that gets me through the event.
So there's a huge psychological aspect to breathlessness, which unfortunately, as physicians, as respiratory physicians, we're not really trained, or we don't really don't have the expertise to deal with that. So I think we just shove it under the carpet. You know, we just want to look at lung functions, we want to look at CT scans, we want to look at like oxygen levels, but that does not correlate well with the perception of breathlessness. So there's definitely much more that we as physicians also need to learn to how to manage this breathlessness, which is like the whole psychological aspect of it.
Yeah.
Can you share some anecdote of maybe a terminal kind of a condition where you've had a great outcome, which can be like an inspiring anecdote? Can you just think of something that, because while you think of it, I just wanted to share how I was inspired by that home care setup, and that it is possible to do all of that in India.
Yeah.
Prepare yourself,
Yeah.
take care of someone, and respect their wishes.
Yeah.
Of course, so I think, you know, of course, not everybody who comes to us dies.
Oh, all right. We forgot to mention that. And she's like, okay, these guys are just talking about these conditions.
Yeah, like
And they are also,
a-
what is this?
so there's a lot that we do, yeah. So no, so actually, to just give you an example, so you know, the other condition where patients get very breathless is an effusion, or you know, when fluid builds outside the lungs. And the most common cause for that is cancer, as we all know. Now, you know, just building up of the fluid will cause your lung to compress down, and that causes breathlessness. So I recently had this 88-year-old lady who had metastatic lung cancer, who had advanced lung cancer. And she had 3 or 4 hospital admissions for this fluid building up, where they had to put in a tube, you know, get the fluid out. The getting of the fluid out used to be very painful for her, very uncomfortable. And within a span of 3 months, she had 4 of these kind of episodes. And that's when we decided to put this semi-permanent catheter, or an indwelling pleural catheter. So that's a catheter which just remains beneath your skin, and you can drain the fluid as and when you want, and as and when you
like a valve, you can open it if there's an excess.
Yeah,
buildup,
exactly. So
on.
through the bottles you
Yeah.
just drain the fluid. And it's been 7 months since we inserted it.
Wow.
and she's not had any hospital admissions. They drain the fluid as and when she gets breathless, which is like
And they're in
once in.
control of the situation.
They're in control. So she,
Amazing.
she's 89. She has great grandchildren who visit her every week. 2 sons live with her. She's very happy. Went to the village couple of months back, and of course they're just very happy to just manage her at home, do everything at home. So again, like I think just at times like doing certain interventions,
Oh,
also.
yeah.
So it's not always about not doing things.
Yeah.
At times, like in this case, like putting in that catheter, it turned out
Interesting.
very useful for her in the
Amazing.
sense that at least she's out of hospital.
Yeah, and because nowadays, again, just for people who are listening, we'll start with a disclaimer that not everyone who comes to the pulmonary OPD it's like. So what we'll also talk about is a lot of interventions that are done in pulmonology. A lot of
Yeah.
stents can be
Yeah.
Things can be, tubes can be put in,
Correct.
specialized high tech stuff can be done. So
Absolutely.
could you just talk about one or two of these so that we understand that?
So the main things that you would do is something like indwelling catheter for like recurrently filling up effusions, possibly most likely secondary to a cancer. The other thing is that if your lung has got completely collapsed because of a tumor, because of cancer, and that's causing you to be extremely breathless, then you can put in a stent, which is again a very temporary phenomenon. It's not going to prolong your life, or it's not going to make you live longer, but it's just going to improve your quality of
Okay.
life by making you less breathless because your
Yeah.
lung gets expanded. So that's stenting is the other thing that can be done. What else can we do? So these and of course for like advanced COPD, there are like some valve therapies, where you can like block certain parts of the lungs. That can again help to reduce breathlessness, but that's a very advanced. So there are certain interventions which we can help with, but depending on the condition.
Yeah.
Generally in
Yeah.
interstitial
So
lung.
we are not specialists like you,
Yeah.
so we wouldn't understand that. So
Correct.
this is your chance to kind of say all the good stuff that you do.
To sell myself.
To sell yourself good things, so that. But I will say this, like having spoken with you and having interacted with you, and since we work in palliative care and we
Yeah.
see people who are suffering and families who are suffering, it is very again heartening to hear that there are people out there are specialists like you. I'm sure there are many pulmonologists who are on the same page as you now,
Yeah.
who talk about these things, who are honest, having clear conversations, not
Yeah.
giving false hope, thinking in terms of the best interest of the patient and the family, trying to reduce their suffering. And that's very heartening to hear. And I'm very happy to know that people like you who have so much expertise in this branch are here in India doing a great job. So I'm just happy for that.
Oh, thank you. That's really kind of you.
We have one final question for you. What does living well mean to you?
I think living well is a very holistic approach for me. I think living well would entail like all aspects of my life, that whether professionally, personally, spiritually, emotionally, intellectually. If I can do well in all these aspects, that means living well for me.
Perfect.
Beautiful.
Perfect.
So once again, thanks a lot for joining us, Smriti. Any closing remarks?
Thank you, Radhika. Thank
No,
you so much.
Thank you so much, Smriti and Mahesh. It was an absolute pleasure being here.
Thank
Thank
you.
Thanks.